and then you infuse it back into the patient 3 days later, and it stimulates or basically educates other cells in your immune system that are called the adaptive immune system, B cells and T cells, that then will go out and target the tumor or make antibodies against the tumor. So this has been around since almost 20 years now, and it's FDA approved for showing a survival benefit in men with metastatic castration-resistant prostate cancer. Doesn't have a lot of side effects, maybe some fever, shakes, and chills with the second or third infusion, but it didn't get huge uptake. And I think there's a lot of reasons for that. Part of it is that PSA doesn't usually go down, and part of it is that the data probably shows that it works best for those that have lower volumes of disease, lower PSAs, etc. It's not ideal for somebody who needs treatment, boom, right now, that needs to kind of get on top of the cancer. And for that reason, with the field changing so dramatically and all the new therapies that have come along, I think that it's probably not used that often anymore. So we use it once in a while, but I would say it's a small chunk of the pie for patients that get treated with it. So that's kind of my brief summary of, but I'm happy to talk about it more if anybody has questions, or James, you may have questions about it while I try to reload my water. Can you believe I spilled 2?
Almighty is right.
If I was almighty, I'd just kind of fill the glasses back up again.
So absolutely, and we do know that you can get these activated immune cells with the Sapula cell T, and these activated immune cells are the ones that can go through and potentially recognize and attack the cancer cells, and that's the whole idea here. It's interesting to me that, as you mentioned, those patients who had lower PSAs in the study, it was a retrospective look, meaning that it wasn't designed, the study wasn't designed to look at this, but when they looked at it, what they found is that those patients that had the lowest quartile, the lowest quarter of patients that had PSA, so that was 22, a PSA of 22 or less, those patients actually did much better than the median of the group as a whole. So, on general, the improvement in overall survival was 4.1 months, but in that group of patients that had a PSA of 22 or less, those patients actually had a 13-month improvement in survival compared to just the control arm, which was just the infusion product minus this fusion protein that Emma talked about. So that was one interesting caveat. And then another interesting thing that we've learned as Sapula cell T has rolled out is that there appears to be more of an impact in African American patients. In other words, in general, the improvement in overall survival or survival that you're seeing is around 25 months for patients overall, and for Caucasian patients especially. But if you look at the African American patients, it was closer to 35 months. So suggesting, again, this is looking at the data as it accumulates, it's not a randomized data look, but suggesting that there may be even more activity in looking at different biology. So we're still understanding what that might be caused by, but there are some other studies ongoing looking at other immunotherapies in African Americans versus Caucasians, and we're finding some really interesting things about the biology that we didn't actually know before when it comes to cancer. Questions?
So can we infer that from what you just said, that the research is continuing, or has it peaked out?
Yep. So great question. So it is FDA approved now. I would say that there are, occasionally we see new trials popping up, and there's one that just opened. And this is one, instead of giving 3 infusions every 2 weeks, they're giving those 3 infusions, and then 6 months later, they're giving another infusion to see, can people do better with that? The primary endpoint of that study is immune-based, so they're going to be looking at the ability of the patient's immune system to get going, and it'll be randomized between standard of treatment and with 3 and this experimental arm with 4 to see if there's any better immune activation. In addition, they'll be following patients for survival, but that's a secondary endpoint.
I'll just add, I mean, I kind of think that study should have been done a long time ago. It makes a lot of sense. I mean, some of us get flu shots and COVID shots. I just got both of mine last night, and you know, you don't just get one and done. You know, you get them over and over again. So it kind of makes sense.
Yeah, absolutely, absolutely. Great question. So, kind of moving the treatment earlier on in the disease setting makes a lot of sense, and so this is kind of a prevention study, if you will. So we're trying to see, or they were trying to see if they could prevent the cancer from being clinically significant, prevent somebody from needing to go to surgery or radiation therapy. So some people with active surveillance, you know, over time, you get your biopsies every year and you follow the PSA, et cetera. Some of those patients will go on to require local therapy if they are in that group of patients that still should be looked at for curative intent. They don't have a lot of other bad health problems that might make them not, that might make the risk of dying from something else higher than the risk of dying from prostate cancer.
And I'll just add to that, I mean, if you look at the data for active surveillance, probably half the patients, maybe even more, will drop off active surveillance at some point in time. And that's for various reasons. Sometimes it's because, you know, the rebiopsy showed the Gleason score was higher or the grade grouping was higher. Sometimes it's because the PSA goes up and there's anxiety. It can be doctor anxiety, patient anxiety, or combined anxiety. And sometimes there's just discomfort with the idea of active surveillance. So just because patients embark on it, you know, there's plenty that come off of it. And so, I mean, if there are methods to help prevent or delay the need for active treatment, that's well. Yeah.
So thank you.
Just a quick word. While I'm very honored to accept this on behalf of the Delaware Prostate Cancer Coalition, it really is a recognition of a team effort. And I just wanted to publicly acknowledge some of our board members who just give up themselves tirelessly. So board members that are here could just stand up and be acknowledged. First of all, we have Dr. Fran Franklin. She's a professor at the Delaware State University and a tireless champion for the cause. Next we have, you've heard about David Saul's previous Spirit Award winner, James West Spirit Award winner. He's our Energizer Bunny. He attends every single prostate cancer event in healthcare in the state. And then we have Mr. Ricky Hardy, who spearheaded a very successful prostate cancer support group. He brings to us some very impressive oratory skills, which he has honed in his second life as a preacher. And last but not least, my biggest supporter, my cheerleader, and always here to lend a hand in anything involved with the Cancer Coalition, my wife of 34 years, to this day, stands there. She always wanted to spend her 34th anniversary here in Washington, D.C.
Thank you so much, everyone.
Off something toxic in the cancer cell to then disrupt its DNA, disrupt its replication, disrupt its microtubule system, something that's toxic, oftentimes so toxic that if you just infused it into a patient, it'd be too toxic for the patient to handle. So you want it protected and only activated when it gets to the cancer cell. And then very importantly is the linker, okay? This is incredibly important because this linker is what fuses the antibody to the payload, to that chemotherapy backbone and keeps it inactive until it gets to where it needs to get. All right, which is obviously in the cancer cell, because that's the goal there. And these linkers, there's many different linkers, but some of them are more cleavable than others. Some of them are cleaved in physiologic environments, and some of them actually get inside the cancer cell and aren't cleaved until they get a really, really low pH, a really low acidic environment inside the cancer cell. So I'll show you a little bit more with this diagram. Okay, so this is a diagram of a fairly non-cleavable antibody-drug conjugate, and the whole idea is that your antibody comes up and finds that target protein, that antigen binds to it, and then something called an endosome occurs, where basically it gets brought in, or almost eaten into the cancer cell. That endosome will fuse to something called a lysosome. A lysosome, the way to think about it is it's a little bit like the garbage can in the cell, where there are obviously proteins that are old and you don't need them anymore, and you need rapid activation, deactivation, and you can degrade those there and get rid of them there. So an endosome, when it fuses to a lysosome, that pH is very, very low. It's a very acidic environment, pH 1, and that's how you design your linker, so that it's, boom, cleaved there and can release its toxic payload inside the cancer cell. So pretty cool. I like it. So with that being said and done, I think that's what I'm talking about today. Nectin-4 is a target that nobody really thought about. And so I'm going to bring out the bladder cancer researcher in me first, because there is an FDA-approved agent for bladder cancer, and it's called enfortumab vedotin. Originally, it was made by a company called Agencis, and called AGS22E. But Nectin-4, it almost, I'll just point this out, it almost doesn't matter so much what the protein is meant to do. What matters is the expression level of the protein, so that you can actually use it as a target to drop your payload off at. And so it has activity, cell-cell adhesion, etc. There's all, the activity and active function of it is actually not so well described. But it was found to be pretty highly expressed in bladder cancer. And originally, the early studies was like it was, in the 40% range, 60% range. Subsequent studies, we found that it's actually super highly expressed in bladder cancer and in some other cancers as well. So I said that clinical data show very high H scores with enfortumab vedotin. One unique thing with enfortumab vedotin and how they did this is their antibody on their antibody-drug conjugate is the same antibody they use to stain the tissue with. So it's the exact same antibody. They get really, really high expression scores when they look on the tissue, and then they treat it. It's so high that it's almost not worth doing as a biomarker. It's like one might think high score means you're going to respond better, low score means you won't respond as well. But scores have been uniformly very, very high with this agent. So I'm just going to show this real quick. This is the phase 3 for tips toes. Some people can get motor neuropathy as well, where it's hard to move certain components. So that's a big deal when it happens. It can cause rash as well. It can cause, some high glucose levels as well. There's toxicities, and there are patients that require dose interruptions, dose reductions, dose delays, etc. So keep this in mind as we think about moving it forward into other cancers and with potentially other agents, other antibody-drug conjugates. So that was all about bladder cancer, and I'm going to draw analogies back and forth because, again, I was talking at this table here earlier, when you're a barber, what's going to happen? You're going to cut some hair, right? So I do GU cancer, so I'm going to draw analogies between one GU cancer and another GU cancer. This is some data from the TCGA analysis, and the one critique I'll give you is this is RNA expression. This is not protein expression. So it's a rough look. It's not 100%, validated. There's very little protein expression data across tumor types and Nectin-4. Okay, but as you can see, what's highest on the list of expression is UC, which is urothelial carcinoma. But there's lung cancers, there's head and neck cancers. Where's prostate cancer? Let's get back to our original topic. Prostate cancer is there. It's reasonably expressed, at least at RNA level. But, it's not the most highly expressed compared to some tumor types. But there are some studies ongoing. There's at least one ongoing. And this is for patients with metastatic castration-resistant prostate cancer who have received one novel hormonal agent, like an abiraterone or an enzalutamide, and chemotherapy with docetaxel. This is using enfortumab, that same drug that I talked about that's FDA approved for bladder cancer. but they're planning on adding other cohorts as combinations. So this is just an ongoing study using enfortumab as an antibody-drug conjugate in prostate cancer. But I mentioned toxicities, and there's no free lunch in life. This is supposed to be better than just giving chemotherapy, right? Because it's supposed to concentrate in the cancer cell. But you still get spillover. And sometimes that's good. Sometimes you get what's called bystander effect. You might not have every cell in the cancer tumor in the mass that expresses Nectin-4. Maybe if you hit it and you get a little leakage there, you get some good effects there by killing off those cells as well in the local microenvironment. But by and by, our goal is to try to maximize efficacy and minimize toxicity. And so this is a small company I'm working with, Corvus. They have an agent called CRB701, okay? And this is a different antibody-drug conjugate. It binds to a different site on Nectin-4, and they have a different linker as well. They have the same payload, which is a anti-microtubule inhibitor as enfortumab, but the antibody is different and the linker is different. And it's supposed to have longer circulation, so you can dose it instead of every week, like enfortumab is dosed. This can be dosed every 3 weeks, and that's kind of nice for patients. There's also less circulating MMAE, which is the toxic payload. So obviously that's good. You want it concentrated in the tumor so it's not circulating around causing side effects. And something called the DAR, drug-antibody ratio. That's when you have this construct, how much of the drug actually is packed on to the molecule, okay? One might think the more drug you pack on, the better. That's not always true. Sometimes you pack too much drug on, you get more toxicity. So this is like a 2-to-1 ratio. DAR's 2, 3.8 for enfortumab vedotin. I don't exactly understand why this is, but this monoclonal antibody has 2 times the speed of internalization inside the cell, and this is a site-specific and cleavable linker. Now, some in vivo work in animal models, I'm sorry, this is not animal model, this is PC3, prostate cancer cell lines. This basically shows that CRB701 in this cell line seems to have better efficacy as you dose up. And you can guess what standard of care is. I just talked about standard of care. They just didn't want to call it out there. So, the whole idea here is if you can get better concentration in the tumor and less circulating around, you might get less toxicity, but you might also have potential to treat patients who have tumors that don't express tons of Nectin-4. What if you have a cancer that isn't like bladder urothelial cancer that expresses tons of Nectin-4? Maybe if you have moderate expression, that's going to be good enough to really show activity and efficacy. And that's where I think prostate cancer is this more moderate expression of Nectin-4 with this different new class of agents. That's not a new class, but with maybe generation 2, we might see better efficacy and less toxicity. Still early, but here's a little bit more data. And you can look at the graphics on the left, but the whole point of this data is to show that when you infuse this agent, what you get is you get a lot of the construct floating around in the bloodstream, not a ton in the tumor. But what you get a ton of in the tumor is actually the payload. It's depositing that payload in the tumor and not so much in the bloodstream. And so the whole idea here is that's how you get more efficacy, anti-tumor efficacy against the cancer and less potential